On May 20th, 2016, the U.S. Department of Health and Human Services Office for Civil Rights issued a guidance document with recommendations for nursing facilities to ensure Section Q of the MDS is properly completed and appropriate referrals are made to the local contact agency, which is the Department of Human Services, Division of Long-Term Services and Supports. Section Q is designed to assist residents in returning to the community or another more integrated setting appropriate to their needs. Section Q questions provide the resident with the opportunity to learn about services available to him or her in the community-based settings in which the resident can choose to receive services in the community. The resident is also provided with the opportunity to seek a referral regarding potential transition to the community.
These agencies, organizations, and associations have collaborated to provide this training on Section Q. This presentation will include the rationale for Section Q, identify the local contact agency, and explain the steps for making a referral to the local contact agency. Questions may come up to you as we move through each slide, which hopefully will be answered in the later slides and by the end of the presentation. The U.S. Centers for Disease Control and Prevention defines aging in place as the ability to live in one's own home and community safely, independently, and comfortably, regardless of age, income, or ability level. As we think about what it means to age in place, most of us want to remain living at home and in our community surrounded by family and friends, the places we like to frequent, and activities that are familiar and give meaning to our lives. According to a U.S. Census Bureau report entitled An Aging World 2015, in the U.S., people aged 65 and older comprise 14.9% of the total population. By 2050, people aged 65 and older are expected to comprise 22% of the population. The average life expectancy in the U.S. is 79.9 years. Nursing facility residents may be able to return to the community if provided appropriate assistance and referral to the home and community-based services and other community resources.
Section 504 prohibits discrimination based on disability, including the unnecessary segregation of persons with disabilities. Unjustified segregation can include continued placement in an inpatient facility when the resident could live in a more integrated setting. The Office for Civil Rights is responsible for enforcing Section 504 as it applies to entities that receive federal financial assistance through the U.S. Department of Health and Human Services. Nursing facilities receive this federal financial assistance through Medicare and Medicaid programs. Section Q assists long-term care facilities and the state to comply with their civil rights obligations by appropriately administering the minimum data set resident assessment, commonly referred to as the MDS. Important progress has been made so that individuals have more choices, care options, and available services and supports to meet their care preferences and needs in the least restrictive setting possible. This progress resulted from the 1999 U.S. Supreme Court decision in Olmstead v. LC, which states residents needing long-term services and supports have the right to receive services in the least restrictive and most integrated setting. The unnecessary placement of an individual in a long-term care facility may constitute discrimination under Section 504 of the Rehabilitation Act and Title II of the Americans with Disabilities Act, as interpreted by the U.S. Supreme Court decision in Olmstead. Section Q assists the state in meeting its non-discrimination requirements under Section 504 and the American with Disabilities Act. All individuals have the right to choose the services they receive and the settings in which they receive those services. Section Q connects residents living in long-term care facilities with the opportunity to age in place in the most integrated community setting. Care plans must be individualized and person-centered. Whenever possible, the resident needs to be involved in the conversation. Each resident must have a discharge plan, which is included within the care plan. A resident's discharge goal or goals are established through discussions with the resident and family. Goals can be based on the resident's functional status, prior functioning, medical conditions, medical treatment needs, and expected treatment outcomes, discussions with the resident and family, and the resident's motivation to improve and return to the community. The resident is at the center of decision making. Interviewing and listening to the resident will enhance an understanding of the resident's expectations as expressed or communicated by the resident, which is integral to care planning and discharge planning. Some residents may be unable to provide clear responses. Others may be unable to communicate his or her preferences either verbally or non-verbally. In these cases, the information can be obtained from the family or significant other as designated by the resident. If family or a significant other is not available, the information should be obtained from the guardian or legally authorized representative.
Interviewing the resident or designated individuals makes the resident or their family at the center of decision making. Residents who are actively engaged in the assessment process and in developing their plan of care through conversation and interview often experience improved quality of life and higher quality of care, which is based on their preferences, needs, goals, and priorities. The resident's overall expectation needs need to be individualized and resident-driven rather than what the facility staff judge to be the best interest of the resident. The resident should be asked about his or her own expectation of returning to the community and their goals for care. The resident may not be aware of the option of returning to the community and that services and supports may be available to meet their long-term care needs. Additional assessment information may be needed to determine whether the resident requires additional services or supports. Do not guess at what the resident might identify as a goal or judge whether the resident's goal is appropriate or not. If this question is answered as the resident plans on discharge from the current facility, the skip pattern is not valid. South Dakota Department of Health will focus on this question and how it is answered along with question Q400 and Q500.
Returning home or to a non-institutional setting can be very important to a resident's health and quality of life. Even residents who have been in the facility for a long time need to be routinely engaged in the conversation. Adequate discharge planning will decrease the chances of rehospitalization and extended aftercare.
Care plans should include name and contact information of primary care provider chosen by the resident, arrangements for durable medical equipment if needed, formal and informal supports that are available providers in the community to meet the resident's needs, and where the resident is going to be living.
The discharge planning process begins shortly after admission with a focus on the resident's discharge goals. The resident must be involved in setting goals and making decisions. An active discharge plan is a discharge plan that is currently being implemented. The resident's care plan has current goals to make specific arrangements for discharge. Staff are taking active steps to accomplish discharge, and there is a target discharge date for when it is anticipated the resident will be able to discharge. A successful transition from the facility will depend on the availability of services, settings, other formal supports, and informal supports from family, caregivers, friends, and neighbors.
If question Q400 is answered yes, the resident is currently being assessed for discharge by the local contact agency, or the resident has a transition plan in place for the services and the assistance he or she may need upon discharge is part of the resident's current discharge plan.
In addition, question Q400 is answered yes when the resident has an expected discharge date of 3 months or less, has a discharge plan in place, and the discharge plan could not be improved upon by making a referral to the local contact agency. If the nursing facility needs assistance in developing the resident's discharge plan, a Section Q referral to the local contact agency can provide information on available community living options, home and community-based services and supports, and community providers to meet the resident's individual needs upon discharge. The process for making a referral to the local contact agency will be explained in upcoming slides.
If active discharge planning is not occurring, then the facility must ask the resident the follow-up question. Do you want to talk to someone about the possibility of leaving this facility and returning to live and receive services in the community?
Question 500 identifies the resident's desire to speak with someone about returning to the community. It also includes the nursing home supporting the resident in achieving his or her highest level of functioning, and the local contact agency providing information and choices for community living and services and supports available to the resident in order to transition to community living. Residents are asked directly to formalize the opportunity for the resident to be informed of and consider his or her options to return to community living.
When the resident responds yes to question Q500, a referral to the local contact agency is required. When asking this question, facility staff can explain to the resident that this question is intended to provide them with the opportunity to explore the possibility of living in the community, to get information on the different choices of community settings and services to receive the ongoing care that he or she needs. The resident should be encouraged to learn about the possibility of returning to the community by talking to the local contact agency. Most residents do not know what alternatives to facility care exist, so the word possibility in the question is essential. Asking the resident about whether they want to talk to someone about returning to the community offers the resident choice and respects his or her preferences and wishes.
A yes to Q500, do you want to talk to someone about the possibility of leaving this facility and returning to live and receive services in the community, does not commit the resident to leave the facility or to leave within a specific period of time. A yes does not ensure the resident will move back into the community. Likewise, a no to the question is not a permanent commitment by the resident to remain in the facility forever, because the resident can change a no to a yes at any time.
Does the resident want to be asked about returning to the community on all assessments or only on comprehensive assessments? When the resident is unable to understand or respond, does the family's significant other, guardian, or legal authorized representative want to be asked about the resident returning to the community on all assessments? Residents who express interest in leaving the facility or learning about how to return to the community, either through answering yes to Q500 or by expressing their interest to direct care staff at other times, must be referred to the local contact agency. Once any facility staff learns of the resident's interest, a referral to the local contact agency must be made in 10 business days, which is considered a reasonable amount of time. The referral needs to be documented in the resident's discharge plan. Q600 documents if a referral has been made to the local contact agency. On Q600, mark no, referral not needed, if the resident's discharge planning has been completely developed by the nursing facility staff and there are no additional needs that the facility cannot arrange for. Mark no, referral is or may be needed when a contact may be needed but the referral has not been made at this time. Follow-up documentation will indicate the status of discharge planning and why a referral was not made. Mark yes when a referral has been made. Residents can choose where to receive services and cannot be influenced or pressured to remain in the nursing facility. The facility cannot insert judgment as to whether a referral to the local contact agency is appropriate for the resident or not appropriate. Facilities must not deny residents a referral to the local contact agency. The facility cannot override the resident's expressed interest based on factors such as a belief that the resident's disability is too severe to transition, or a belief that discharge is not possible because the resident has no home or support in the community, or because a previous transition was not successful, or because the family or caregiver does not want the resident to move. The only reasons the facility may refrain from making a referral to the local contact agency is when requested by the resident or when the resident has an active discharge plan with an anticipated or target discharge date. The Department of Human Services Division of Long-Term Services and Supports is the local contact agency in South Dakota. The nursing facility and LTSS can work together to talk with the resident and their family, guardian, or caregivers about the possibility of returning to the community and explaining the home and community-based services available to meet the residents' needs to transition to the community. Nursing facilities can make a Section Q referral by contacting a local LTSS office or by calling an Aging and Disability Resource Connections call center. Though the Department of Human Services, LTSS, there are 5 Aging and Disability Resource Connection call centers with the toll-free 1-800 numbers as shown on this map. On the map, the towns in blue represent the local LTSS offices located throughout the state.
When nursing facility staff call, please state that you are making a Section Q referral. When a referral is received, it is assigned to a specialist in a local LTSS office for follow-up. The specialist will provide options planning to the resident and or family members or significant others. Options planning includes information, education, and decision support on the home and community-based services and other resources available in the community. Here are some facility considerations. How are residents and family guardians involved in the assessment process? How is their input obtained? How are referrals to the local contact agency being documented? How are community partners pulled into discharge planning discussions to collaborate on available options for residents?
Do facility staff have access to information on options for community living services and supports and local, community, and statewide resources? Does facility staff training include how to talk with the residents and family or guardians about the possibility of returning home and presenting all of the available options?
Now we will cover some frequently asked questions.
When do I need to call the ADRC or a local LTSS office? Who do I need to talk to?
Introduce yourself and tell the specialist who answers the phone that you are calling to make a Section Q referral.
What if I make a referral and nothing happens after 10 business days?
Contact the ADRC or local LTSS office and ask if the referral was received. If yes, ask when follow-up will occur. If no, make the referral again.
Will the facility be cited by the Department of Health if the local LTSS office does not respond to the referral in a timely manner?
No.
Is discharge planning the responsibility of the facility or LTSS as the local contact agency?
Discharge planning of nursing facility residents is the responsibility of the nursing facility.
Do I need to make a Section Q referral for a resident on a short-term stay for rehabilitation?
A referral may not be necessary if there is an active discharge plan in place that includes home health services or home and community-based services, including durable medical equipment, assistive devices, etc. Or when a resident has informal supports and finances in place to discharge without services or assistance to return home following a short-term stay.
For question Q500, do you want to talk to someone about the possibility of leaving this facility and returning to live and receive services in the community? What if the resident has a court-appointed guardian, but the resident answers yes on question Q500?
When the court has given the guardian decision-making authority over a resident's care and placement, and the guardian does not agree with the resident's desires, a referral should be made even if the resident has a legal guardian or a durable power of attorney for health care. Information and education can be provided to the legally authorized representative and to the resident.
Do I make a referral when a resident who has dementia wants to talk to someone about returning home, even though he always answers yes to this question, but has no idea that he cannot stay home alone due to his memory loss?
A referral needs to be made because he responded yes. A referral may be appropriate for a resident who has dementia. People with this diagnosis may be able to live at home with the right services and supports from in-home providers and or family members and other caregivers.
Am I raising a resident's expectations only to see their hopes dashed by asking this question, Q500?
We should never promise more than what can be possible. A referral is the beginning of a process to determine if the possibility can become a reality for the resident.
Who's responsible for follow-up after the resident discharges back into the community?
If the resident discharged from the nursing facility and is receiving services through long-term services and supports, then a specialist will provide case management follow-up with the individual.
If the response is no to question Q550, does the resident want to be asked about returning to the community on all assessments? Does the facility have to perform active discharge plans for that resident?
Each resident must have a discharge plan, which is included within the care plan. This resident will have a discharge plan, but an active discharge plan may or may not be in place for a resident who responds no to Q550.
Do discharge plans need to be completed on all residents, even the residents with a Level 2 PASSR?
Discharge plans need to be completed on all residents, even residents who have Level 2 PASSRs.
What if family is not around during the assessment completion?
You can plan ahead when the assessment is due and prearrange a conference meeting or call with the resident, family member's guardian, and discuss assessment items. If family cannot be present during the assessment, complete a follow-up later, at a time that is convenient to the resident, family member's guardian, to discuss assessment items.
Listed on this slide are some guidance and resources available regarding Section Q. If you have any questions on how to code Section Q, contact the State RAI MDS Specialist at the Department of Health, Adina Ziegler, 605-773-3674.
Through the CMS product ordering site, you can order free products by setting up an account and giving an explanation, such as you are a nursing facility and need products in Section Q, discharge planning, Medicare, to provide to residents, family members, and caregivers. You can also order a discharge planning checklist for individuals and caregivers who are preparing to leave a hospital, nursing facility, or other care setting.
This concludes the training on Section Q. Thank you to those agencies who have collaborated with this training.